Welcome all to another webinar of Locomotion. I'm sure many of you have been attending other webinars of Locomotion and hope they are useful. We've done them on a range of topics, and if you remember, we started off with doing topics of dysautonomia and C19-YRS. So today's webinar is a short session, is half an hour, is again on C19-YRS. The only difference being the first one we did was on what is called the traditional or conventional kind of way of assessing a PROM. And we're looking at C19-YRS, obviously. And today's topic is more about RASH, which is more like a modern way of assessing outcome measures. And I have great pleasure in introducing Dr. Mike Horton, who's the director of the psychometric lab in Leeds, and he's got immense experience for the last more than 10 years of working in rash analysis and outcome measures. And his work in Locomotion has been looking at this kind of modern rash analysis for the outcome measure, and he's going to present some findings, which I'm sure we'll all enjoy. So over to Mike.
Okay, thank you very much, Manoj. I am going to share my screen. Okay, can everybody see my screen? I just need a yes from somebody.
Yes.
Yeah.
Thank you. Right, is that okay? Everyone can see that?
Yep.
Yeah, great. Okay, thanks for the introduction, Manoj. I noticed that you went straight into mentioning like rash and modern measurement theory, but actually this presentation I've kind of cut out all of the technical details, and it's just kind of about how we try and measure the impact of long COVID on individuals, which is I know a very important topic to probably everybody here today. And show some of the development in terms of what we've been doing. So I've got some history of the C19 and kind of the development process that it's gone through. So I've got a slide here about long COVID, but I'm fairly sure that the audience won't need any additional details about long COVID or post-COVID syndrome. It affects over 2 million people in the UK and more than 50 million cases worldwide. Again, as you probably know, there's more than 200 symptoms listed across 10 organ systems. So it's not going to be the easiest thing to measure because it's quite variable among each individual, and it's also quite variable from day to day as well. So we need to try and capture any changes that we can in a timely manner, really. So in terms of actual the measurement of it, so when a person has long COVID, how do we actually measure the impact of this? So this is it might be obvious to some people, but just going through the process of how we measure these things that you can't actually measure directly. So so just in terms of measurement, when we think about measurement, most people would think of measurement in the physical sciences. When you mention measurement, we think about things that you can directly measure with an instrument of some sort. So measurements in the physical sciences are typically done directly with these well-established and calibrated tools like scales and weighing scales and rulers when we're looking at distance or length. And time, obviously, we've got a stopwatch there. And people are very familiar with these. And if we had like a direct instrument that we could measure the impact of long COVID with, then obviously we would try and use that. However, as we know, some things are not directly observable. So things that are more internal, that we can't measure directly with an instrument like a stopwatch or a ruler. So things like depression, quality of life, educational attainment, and potentially the impact of long COVID as well. So when we're trying to think about measuring these indirect aspects, measuring these things that we can't measure directly, we have to create questionnaires or scales which are designed to elicit responses. And these responses would indicate a measure of whatever it is that we're trying to measure. In this case, it's going to be like the impact of long COVID, or the level of long COVID symptomology, or whatever. And in the healthcare sphere, these are usually called patient-reported outcome measures, or PROMs, which you may well be aware of. So when we are creating a PROM, or setting out to develop this PROM, this patient-reported outcome measure, there's lots of sort of tests that we need to do to make sure this does what it's meant to do. So these PROMs should be relevant. They need to be understandable to the people that are responding to them. They need to measure what they're meant to measure, so like long COVID impact in this case. They need to be correctly targeted, which means that that they need to be aligned to the patient sample that they are meant to be measuring. They need to operate properly in terms of the actual measurement structure. And they need to work in a consistent way as well. You've probably heard the term reliability. That's just like a consistency, whether something acts in a consistent, reliable way. And we also, when we're looking at PROMs, we need to consider whether the total score makes sense. So often you'll get given a PROM and they'll have lots of different questions on it. And we need to think about whether you can actually add up all of those questions into a sensible total score. So on the example that I've got on screen here, each of these individual elements is relevant in terms of its content individually, but when you consider them all alongside each other to add them up into a total score, it's actually complete and utter nonsense. So this is what we're obviously trying to avoid when we are developing a PROM for anything, really. So in terms of some background about the original C19-YRS that was developed, this was developed pretty quickly, actually, when long COVID first sort of came onto the scene, when people first became aware that this was a condition that was emerging and was different to just COVID. So the C19-YRS PROM was developed rapidly in response to the global pandemic, and it was initially developed in order to follow up COVID-19 patients following hospital discharge. Sort of, I guess now we know that it was as they were sort of transitioning into long COVID patients. But the primary purpose was for signposting patients towards appropriate treatment pathways. So that's how it sort of started out. That was the background. And it was developed by a multidisciplinary team of rehab professionals, and the content of it was based on a consensus method, based on both their clinical experience, so the clinical experience of the group collective, and also a systematic review of outbreaks of previous similar conditions, such as the previous SARS pandemic that was around a few years ago. Furthermore, they went on to look at the content validity and the face validity to make sure that it contained relevant questions and that it made sense. And this was supported through focus groups, both with patients, long COVID patients, and with other healthcare professionals that worked in the area. So I've just put a note here that I'm going to be talking about items quite a lot during this presentation, and just to interpret, when I say item, it just means a question on the scale, question on the patient-reported outcome measure. So an item is a question. So when the original C19-YRS was developed, it had 22 items across 4 separate subscales. And these 4 separate subscales were symptom severity, functional disability, overall health, which was a single item, and also an other symptoms subscale, which just contained 6 items. And at this point, at the original on the original scale, all of these items, all of the 22 items, were all scored on a 0 to 10 numerical rating scale, with the 0 being symptom not present and a 10 representing symptom extremely severe or life disturbing. So the original scale was assessed, and actually we made some modifications to this. And the modifications were based on the same sort of thing that I'm going to be talking about today, essentially like whether the scales work properly, whether they do what they're meant to do. So it's based on those scale assessments, as well as emerging clinical information regarding COVID-19. Symptoms which weren't covered in the original scale, and they became more and more apparent as long COVID emerged and more symptoms emerged, and also again with some feedback from a working group of patients and healthcare professionals that fed back into the content and the structure and whether it made sense or not. So in terms of the modifications to the original scales, the main change, well, one of the main changes was that the item response structure changed from 11 response categories to 4, and I'll show you about that just in a few slides time. So the original 0 to 10 didn't really work very well in the way we anticipated, so that was reduced down to 4. Some of the items were merged together because they covered very similar content. The other symptoms subscale, which was again originally 0 to 10, this was just changed to a yes/no sort of binary checklist, and extended quite a lot as well. Some items were moved from the core symptom severity subscale into the other symptoms section because they didn't add as much information as we wanted them to. And additionally, some new items were added into the core symptom severity subscale, and these were those new emerging items which weren't initially apparent. So here's just a quick breakdown of some of the changes that were made. So the ones in green were the items from the symptom scale which we remained. So like breathlessness, cough, fatigue, pain, and cognition, they just stayed as they were. There were some items relating to anxiety, depression, and PTSD, and they were combined into kind of a broader item looking at anxiety and mood. And we also had these newly emerging items of smell, taste, palpitations and dizziness, post-exertional malaise, and sleep. And some of the original items, the initial items of swallowing and continence, were moved to the other symptoms scale, as I said, because they weren't providing the level of information that we wanted to in the core symptom set. So with the modified C19, we've got now 2 main subscales, which is the symptom severity scale and the functional disability scale. 10 items in the symptom severity, 5 in the functional disability, which is how they were before, but they're different items in the symptom severity scale. All items are now scored on a 0 to 3 rating scale, which is highlighted on screen. Plus we now have the overall health single item, which is still scored as 0 to 10 because that's a single item on its own. And we've now got this other symptom checklist, this binary yes/no checklist of 25 named symptoms with a tick box response. So a couple of years ago, 2 years, maybe even this week, I presented this at the UK Patient Reported Outcomes Conference. I can't remember where it was, but I presented this there. And I basically stated that these amendments need to be tested prospectively. So we'd made these modifications, but we needed to know whether they worked or not in a new sample. So therefore, moving into Locomotion, the study aim here was to assess and validate the C19 scale modifications that we'd made using a newly collected data from a large-scale multi-center NIHR study, which was the Locomotion study, of which hopefully you're all aware. Methods-wise, so throughout Locomotion, we collected data from nearly 1,300 patients. And the sample was 2/3 female with a mean age of 48, which seems to be very typical of the long COVID population. And these all completed the C19-YRS digitally on the Locomotion study LROS PROMS platform, again, which probably most of you are familiar with, and it was collected on through mobile phones or on screen or whatever. So in terms of the methods, basically we wanted to test the validity of the total score of these scales. And through the methodology which we used, which again, Manoj mentioned it at the start of the presentation, it's a process called like rationalysis. I've not gone into any of the technical details, but the idea is to like reveal any issues in the measurement properties, so that we can potentially like address them within the measurement system. And we looked at subscales separately, primarily the symptom severity scale on its own, and then the functional disability subscale on its own. But we also looked at the other symptoms scale to see if we could use that as an additional standalone scale, which would add some additional information. So in terms of like the good results that we found, first of all, I just want to kind of go through the whole response category structure here. You probably won't, I won't present what this entire graph means, but basically each of these curves that you can see represents a separate response category. So this would be, for example, like not at all, and this would be, I can't remember what they were in the PROM, in the C19, but this would be like the next one, and then that would be like sort of maximal impact. So not at all impact and maximal impact. So when we're looking at a response structure that works, each of these curves should be like emergent. It should, you know, peak at some point, and then the crossover points of these between these curves should like fall in a logical, consistent manner, as was just displayed on screen there. So again, thinking about like the process that we went through, this plot at the top of the screen, this is what the pain question looked like. So I've just used pain as an example, and this is what the pain one looked like with actual data in the original analysis of the C19. And you can see that scale, that plot there, that graph looks absolutely nothing like the one that I've just shown you previously. So none of these are like emergent, which basically means that the response structure is not fully appropriate for the item that you've asked, the question that you have asked. So using the original data, we kind of rescored it in various different ways, and it was implied that a 4-category scoring system would work quite well. And then when we've actually tested this during Locomotion, this one on the bottom is what it actually looks like. So it came out pretty well actually in terms of what we thought it would look like, and how it actually turned out. So in terms of across both of the scales, the symptom scale is on the left, the functional disability scale on the right. Functional disability scale works really well. We can see all the colors on there, and the symptom scale also works pretty well, but not quite as well as we want it to, but it's still pretty good. So we're actually very happy with how all that turned out. Another good thing, which was our targeting, which is basically where we see whether the patients and the scale are actually aligned. So you can see that at the top there, I put where the long COVID patients are located. This is on a common ruler of like long COVID symptomology or long COVID impact. And below we've got like the measurement range of the scale. So we can see we've got a pretty good measurement range here. This is where the green on the top is where most of our people are lying. And then we've got a few which I've indicated with the yellow arrows that kind of fall just outside of our measurement range of our scale, but there's not very many people there. So this is the symptom severity scale targeting, which we're happy with. It's very good. And here is the functional disability scale targeting, which again, we're sort of very happy with. There's just a few people at the floor and ceiling, but not so many that we would be concerned with. So again, the measurement range of the scale is very well aligned with where the sample actually are. So again, does the total score make sense in terms of those separate scales here? And yes, it does in both cases. So we haven't got the nonsense of the Hillsville total score. We've actually got individual items which we can add up into a total score. In terms of the not quite so good, we found one issue with the response structure. So here we go. We've got non-mild problem, moderate, severe. And this was with the smell taste item. And as you can see here, we don't get each of these curves emerging quite as well as we would want. So the implication of this is that the response structure for this particular item, when we consider the content, is probably not fully appropriate to the item content. And this is because probably it was the smell taste item, and it's implying that it's probably acting as like a yes/no response. But what we can actually do with this is to account for it within the scoring and treat it as that yes/no response, which the results imply that it is. Another issue which we found, and this was with the other symptom scale, which I've treated slightly differently and not really included it in the results here anyway. But I wanted to point this out. So sometimes that you can have incompatible items when we're considering that total score again. So here we have this conceptual incompatibility, which implies like a high score that on one item would imply a low score on another item. And this is the example that we've got within the other symptoms scale. So we've got these two items of unintentional weight loss and unintentional weight gain. Each of these is perfectly valid in itself. The content is relevant, but when you consider them together in terms of the total score, then it becomes then a bit nonsensical, because especially when you consider that both of these are in the last 7 days. So again, when we consider this in terms of the total score, these actually don't make a lot of sense, because you can't both unintentionally gain weight and lose weight within 7 days, or certainly not that I'm aware of. So that's very, very rare to find. So the implication for the total score is that we can't actually include both of these items in the total score, because only one will be relevant. However, we can again sort of get around this, because what we can do with it is keep both items for their clinical relevance, but only treat this as a single item. So only include the maximum score which has been observed across both of the items. And when we did that, it actually worked very well. So in terms of addressing the issues found across the subscales, we can actually make various adjustments to the scale, these like after the fact adjustments to make it like to make it perfect, if you like, to make everything work as it's meant to be. And this takes account of the issues that were found. We then actually looked at whether it makes any difference, but the adjusting versus so the adjusted scale versus the unadjusted scale, and we compared the person scores for each separate person with adjusted versus unadjusted. And for the symptom severity score, we found very, very little difference. So these person scores correlate at 0.99, so it makes practically no difference. And with the functional disability scale score, it correlates at 0.999. So there was hardly any problems at all with the functional disability score. So that's reflected there. And that makes, you can see, no difference. A correlation of 0.999 is giving you the same results that it would with not adjusted versus non-adjusted. So again, we're kind of pretty happy with how all this turned out. So in terms of looking at whether the modifications to the original C19 actually improve the scale, again, weighing up sort of the positives and the negatives, thinking about what I said at the start of the presentation, we need these things to be relevant, understandable, etc. And we think that we tick all of these boxes. We've also had like focus groups with patient groups to make sure that these things do make sense. So we know that our measure is relevant, it is understandable, it measures what it's meant to measure, it's correctly targeted, does operate properly, and it also works in a consistent way, which is that reliability that I mentioned earlier. In addition to this, it's reasonably short. It doesn't take very long to complete. It's available in numerous languages. I don't have the amount of languages off the top of my head. Manoj possibly has that information to hand. And a big bonus is that it's free to use. And also it can be used to track individual patient change over time. And I also thought I'd mention here that the other symptom scale, which I haven't really reported on, but that also works well when again, with a couple of adjustments made. So overall, you'd say some minor issues do remain, but these issues are not problematic at all. So I'd say definitely the modifications to the original C19-YRS have improved the scale in terms of the measurement properties, the clinical relevance, and also it's relevant to patients, and they can relate to actually the content that is contained within it. And that brings me to the end of my talk. So thank you very much for listening, and I'm free to take any questions now. Thank you.
Thank you so much, Mike. Are there any questions from the audience? So on a practical level, Mike, can I just check? I mean, as there are no questions, can I just check? So in terms of those two changes which you proposed, and you've also double checked their correlation with the original score, and your correlation is quite high. So on a practical level, what does it mean for a clinician? Do they just carry on what they're doing currently, or?
Yeah, so this is essentially what the test was for, was to see, because it's already, the scale is already out there and being used. So I could go and propose these changes. We found these slight problems with it, so we could make changes to address these problems and go out, collect more data and test them again. But what I wanted to, because from the practical perspective, I wanted to see whether it actually made any difference. So yes, we could make it perfect, but what difference does it make? Going through a whole lot of rigmarole, and actually it makes, so we could make it like perfect, but it makes very little difference to the actual scale that's currently out there being used. So on a practical level, it's much easier just to carry on using it as it is, and just to kind of be aware further downstream that you might, within research studies, we might have to make slight score adjustments to account for, again, for these issues. But on the coal face, as it were, it's going to make no difference.
And I suppose that applies to pretty much every scale out there, isn't it? No scale is like 100% perfect as far as
Yeah, absolutely. So,
okay, okay, we've got Louise, I think. Please go ahead. Oh, sorry.
Oh, yeah. Well, can you hear me? Yes, thank you.
Yeah.
I asked a question in the Q&A, but I don't know if you can see it.
I can see it now.
You can see
okay,
it.
yes.
Yeah. Just asking if the questionnaire is available for wider use, because it would be really helpful. I'm a long COVID patient. Be really helpful as something to have a conversation with your health professionals about.
Yes, I believe so. I think this is the case, Manoj. So I think
yes.
the scale is open and available for anyone to use, as long as it's like a not-for-profit organization or person or individual use, whatever. I think to actually access it, you need to register on like the University of Leeds portal, but you can then just get it for free and use it. And perhaps we can circulate the link after.
Yeah, okay, I'll try to find that. Actually, it is free to use. Actually, I think your question was more around, if you're not attached to a long COVID clinic, is it available for you to use as a patient? Is that your question?
Well, yes, or for my health professionals to use, given that
Yeah.
a long COVID clinic. Yeah, because it would be great to be able to have access to something like that, which is easy to read for everybody, you know, and you can base the conversation around it.
Yeah, absolutely. So you can download it. It's freely available, and we'll share the link shortly, and then you can fill it because it's self-reported, and then you can take it to your healthcare professional. So I think most of the professionals actually are aware of the scale. I'd be surprised actually if they don't know about C19-YRS.
Honestly, Manoj, you'd be surprised what people don't know. Would you be able to share the link as well?
Yeah. I'm looking at it now.
Support and the other groups, because then they can make it more widely available. Thank you. That's really helpful.
Can I just mention that I'm not sure. So the actual like app platform, I don't think that's available across like all healthcare systems, but like the hard copy is. So you know, you can't. Someone's asked about getting like the visuals, so which you get through the app or through the website when we collected them and through the study, but you wouldn't be able to get them if you've just got like a hard copy, paper and pencil version.
Is that Claire's question? Is it? Sorry, Claire, go on. Sorry, go on.
Yeah, that was my question really. I think the visual's always good, like the radar plots or spider plots, whatever you call them. So that comes with the app, does it? And that you could then show it and discuss the visual of it, if you like. With you.
So the only thing about that, as Mike says, Claire, is that the app version currently is linked to health services because NRS works on that sort of agreement.
Yeah.
But for patients to directly use, you would need a free standalone app. And I think LROS is working on it. I don't know when they're going to release it, but they are working on a standalone version which patients can use. And as Louise was mentioning, just download the app, use it, and then take it to your healthcare professional. That version of the app is not available yet. But what services have is the paired version. So whatever you fill in will be seen by the healthcare professional, and then they'll interact with you. That's the version which is currently available.
Okay, but even if those people who are in services that do use the app, that's really great to be able to have that picture, if you like. That's really good. And I mean, I know from the work we've done with you that this really truly has been, we've sat and worked with you, Mike, haven't we, on what's usable for patients. Is it really recording what it's supposed to record? So
yeah, and it's all been like very useful feedback all through the process. So yeah, hopefully it's resulted in a nice usable measure at the end.
Yeah, exactly. Thanks.
I think Barbara has a question. Yeah, it's a tricky one, isn't it, in terms of how services are changing, Barbara. I think I mean, the focus of this talk obviously is on the scale, and our suggestion would be, irrespective of the long COVID clinics, what the PROM does is it actually provides that kind of feedback to the patient, whether it's on an app or a paper form. It's just for the patient itself to sort of reflect on how the condition is changing, fluctuating, what are the needs. Because when you go and see a professional, they give you 10, 15 minutes, and it's very hard to actually tell all your symptoms. So if you go prepared, fill out the questionnaire, then I think it's easier to communicate to any professional. So I think the advantages of the PROM are many. You could also now, as Mike said, you could have a score, and you can also see how your scores are changing over time, whether you're getting better or worse. So yeah, I mean, those are the advantages. I mean, the discussion around what's happening currently with clinics and services is beyond the scope of this webinar, I suppose. It is a tricky one, and I'm sorry about that. And I would like to bring this webinar to a close. The recording of this will be available on our website, as do our other webinars. So please feel free to visit the kind of Locomotion website for having a look at our webinar series. We have a few more coming, I think, and again, the dates of those will be available on our website. Thank you so much. Thank you all.
Thanks, Manoj. Thanks all.
Thank you.
Bye.
Thank you.